From the Columbia Cardiogenetics Clinic, what happens once the patient is referred? The role of cardiogenetics in everyday cardiology practice, a case series. Presented by Jessica Hennessey, MD, PhD, Assistant Professor of Medicine, and Natalie Lippa, MS, CGC, Assistant Professor in Genetic Counseling.
We have an awesome team here that sees all sorts of cardiogenetics patients throughout the system. So Natalie works for all of us, first of all. So she's a busy lady, obviously. I obviously see patients mostly in the electrophysiology space and also in the aortopathy space. Dr. Farhana Latif is a heart failure specialist and sees the majority of the dilated cardiomyopathy patients. Barry Fine is joining our group as part of the cardiomyopathy research aspect of our group. And then on the bottom, we see two physicians and a nurse practitioner, Dr. Murdoch Riley, who really was part of the initiation of our clinic in the first place, as well as Henry Ginsberg, who's our main lipid clinic physician, who's assisted by his NP, Cindy Young. So how do you get to us if you actually do want to refer one of your patients to cardiogenetics? So one, there's orders in Epic, both ambulatory and inpatient. I'm not going to lie, we prefer the ambulatory setting mostly because it gives us some time to really talk to the patients and the families and give the families time to gather enough information to really be relevant for if the need for further testing is in place. The other way is obviously through the internet, as always. Cardiogenetics, if you just type cardiogenetics into Google, it should be one of the top. Columbia Cardiogenetics should be one of the top 3. So sometimes I'll actually just tell patients, because I can never remember the phone number, to just Google it. So if you've referred your patient to cardiogenetics, what are the reasons to actually refer them? The first, and I'll sort of go through this in a pretty quick fashion, is the cardiomyopathies. So we have the hypertrophics, the idiopathics, both ARVC, arrhythmogenic right ventricular, or now just general cardiomyopathy as it's called, and peripartum cardiomyopathy. The arrhythmias, as you all know, are near and dear to my heart, including Brugada, long QT, CPVT, some conduction disease, short QT syndrome. And please note, this list is not exhaustive by any means, and any of these things can be run by us in any way. Aortopathy has become another big part of our genetics group, and those are the major causes of thoracic aortic aneurysm, including Marfan's, Lowy Dietz, vascular Ehlers-Danlos. And finally, the dyslipidemias, those patients who have elevated LDLs and elevated triglycerides in particular. So one of your patients has one of these diagnoses. What happens when they get on this road of cardiogenetics referral? What's really going on? The first thing that I want to emphasize in this that's really important is identifying the proband in the family, and in particular, the proband that has the most severe phenotype, because that'll give us the highest yield for a genetic testing result. We then collect family history and perform pre-test genetic counseling. I'm going to emphasize this one too. Pre-test genetic counseling is huge. We actually do it twice. So Natalie usually calls and speaks to the patient first, gathers family history, and runs through the 3 different options or possibilities as far as genetic testing results go. Those 3 possibilities are positive, meaning we know you have a pathogenic mutation that leads to the syndrome that we're dealing with. The opposite of that is negative, is that there's 0 that is involved genetically that we know of right now that's likely related to your pathology. And then finally, this middle category, which Mike Ackerman from Mayo calls it genetic purgatory, called the variant of uncertain significance, or a VUS. And you're going to see that word sort of sprinkled throughout this talk, or that abbreviation, I guess I should say. These variants of uncertain significance, as you'll see through, are effectively genetic purgatory. We don't know if they're positive or negative, and ultimately do get reclassified over time. And so it's an important aspect to sort of pay attention to as you're sending your patients through cardiogenetics clinic and evaluating their results. Explaining this to patients is one of the most important parts of our role here as well, because they see things that say variant and then they freak out, and then we say no, and it's a back and forth that's important to really understand what we're dealing with. So then once we've done all that, we then actually are going to do some genetic testing, and we use commercially available panels to send for this. And then your next question might be like, the business people in here are saying, wait a minute, these companies are doing this, like, what are we choosing? And so actually the decision of whether a gene is made pathologic or not is really managed by ClinGen, which is this international consortium that gathers a ton of data in order to classify genes as either pathologic, negative, or variants of uncertain significance. And it's constantly being changed. And believe me, we get the emails from the companies. It's constantly being changed, the classification of these. One of their main resources is ClinVar. So ClinVar is something that's also accessible to any of us on PubMed, where the variants that we find with clinical data are deposited into this database to allow for further understanding of various variants as they move forward. Okay, so we got our genetic testing. We all agree which one we were going to do. Then it's up to performing variant interpretation. Some of this is easy, positive, negative. Some of it's less easy, as you'll see throughout the talk, like a variant of uncertain significance can potentially be less easy. But we interpret the variant and then go through some post-test counseling with the patient and ultimately family screening if this is relevant.
This was brought to you by the Center for Precision Medicine and Genomics at Columbia. This has been an internal medicine genetics case study.